Welcome. I'm Cheryl Veracola, Director of Practice Advancement with the North Carolina Association of Pharmacists. And this is a brief recording that will highlight key updates to the 2024 U.S. Medical Eligibility Criteria, or U.S. MEC, for contraceptive use. Please note that the slide segments to follow does not include all 2024 U.S. MEC changes. Instead, we are going to focus specifically on the updates that directly impact the pharmacist statewide protocol for hormonal contraceptives in North Carolina. So now let's take a look at what's changed and what you need to know for your practice. As a point of reference, and as many of you are aware, the updated 2024 U.S. Medical Eligibility Criteria for contraceptive use were released in August of 2024, which replaced the previous 2016 version. On May 20th of 2025, both the North Carolina Medical Board and the North Carolina Board of Pharmacy formally approved a revised version of the Pharmacist Statewide Protocol for Hormonal Contraceptives, which have been updated to align with the 2024 U.S. MEC recommendations. Now, I know you may be wondering, why did it take from August of 24 until May of 25 to finalize the revisions to the statewide protocol? Well, the short answer is there was a great deal happening behind the scenes during that time frame. First, recognize that the updated U.S. MEC recommendations needed to be carefully reviewed to determine their impact on the existing statewide protocol. Once it was clear that revisions were necessary, then the specific changes had to be thoughtfully integrated, not only into the protocol, but also into all of the supporting materials that accompany the protocol. Now, this process involved multiple meetings with stakeholders and clinical experts to ensure that the updates were clearly articulated and accurately reflected in both the protocol and its accompanying documents. It was only after this thorough vetting process were the revised materials ready to be submitted to the North Carolina Medical Board and the North Carolina Board of Pharmacy for formal review. And then, of course, in order to do formal review, both of the boards needed to get it on their docket and their agenda for their board meetings, which took a little bit of time as well. So recognize that all of this was happening behind the scenes during that time frame. But as of this month, I also want you to know that NCAP's Hormonal Contraceptive Toolkit has also been updated to reflect these changes. All included resources have been reviewed to ensure that they remain accurate and are relevant to the U.S. MEC updates and the protocol revisions. Now, in July, we will also do a revision of the hormonal contraceptive training. We realize that the introductory module needs to be updated to incorporate the U.S. MEC changes, and then we will also review at that time other modules within the hormonal contraceptive training to determine whether or not further updates are needed to those as well. So that'll be coming in July. But let's dive into the changes. I think what's important is I want to tell you what updates were needed in the statewide protocol because of the new U.S. MEC recommendations. Now, surprisingly, the protocol itself required very few changes. And I'll explain what I mean in that in more detail on the next slide. But in short, just recognize that the updates to the protocol itself were minimal. They were mostly cosmetic. The most significant revisions occurred in the supplemental materials that support the protocol, specifically the patient questionnaire and the corresponding treatment pathway. These are the two documents that underwent the most updates to ensure alignment with the 2024 U.S. MEC recommendations. Now, remember how I mentioned that the changes to the protocol itself were minimal, mostly cosmetic? This slide helps to illustrate exactly what I mean by that. I'm going to turn on my laser so that I can try to use this during the presentation. It sits on the left. You'll notice, though, that the old protocol, or the old version of the protocol, contained multiple embedded hyperlinks that were scattered throughout the document. Many of these links were duplicative, and during our review, prompted by the 2024 updates, what we found was that many of those links were also broken. So to address this concern, the new version of the protocol no longer includes embedded hyperlinks within the main text of the protocol itself. Instead, what we've done is we've streamlined access to the supporting materials by introducing a new Appendix A, which is located at the end of the protocol. This appendix now houses all of the relevant links to the supplemental documents and the resources that you'll need to carry out the protocol. This change serves really two key purposes. First of all, it simplifies the access to the materials that pharmacists need by consolidating them all in one easy to find location, but it also makes ongoing maintenance of the protocol more efficient. So again, if we were to have changes that occurred in the future, over time, this would allow us to just review this one appendix page to make sure that everything is up to date and all of the links are working. So we wouldn't have to make so many changes to the protocol itself. Perhaps we just need to make the changes to the appendix. So it really does make it easier for the reviewer to consistently make sure that the appendix is consistently operational. Again, this was the minor change. There wasn't necessarily anything within this change that was a result of anything clinically in the revisions. Again, as I mentioned earlier, the most significant and clinically relevant updates stem from the new US MEC criteria's impact on the supplemental materials, specifically the patient questionnaire and its companion treatment care pathway. These slides will walk us through what those changes were, really at a higher level. But the good news is that the updates were really relatively limited in scope. In other words, there were only 5 questions on the patient questionnaire that had to be revised or realigned or moved. And these changes reflect updated clinical guidance related to the following conditions. So there were 4 conditions, one being liver disease, one being sickle cell anemia, systemic lupus, and then chronic kidney disease. Now, each of these conditions had updated categorizations or clarifications in the 2024 US MEC recommendations that warranted corresponding changes in both the pharmacist patient screening process. So this becomes very important moving forward, as it could change your recommendations from what we currently see. Now, as of the treatment care pathway, the updates were primarily logistic rather than clinical. The edits were made to ensure that step numbers and decision points correctly aligned with the revised questionnaire, so helping to maintain that clarity and consistency in the patient assessment and prescribing process. Again, to put this in perspective, this slide highlights the specific questions in the patient questionnaire that were revised based off the 2024 updates. Each of these changes is tied to an updated clinical guidance that directly affects the pharmacist's ability to initiate or refer patients for contraceptive care under the statewide protocol. So if you look at question number 23, which pertains to malignant liver cancer, it now clearly reflects that this condition is categorized as a category 3 or 4 for both progestin-only pills or POPs and combined hormonal contraceptives or CHCs. This means that pharmacists should not initiate hormonal contraception in patients with this condition and should refer them to a primary care provider. Now, for cirrhosis and benign liver tumors, the new guidance kind of lowers the restriction level for progestin-only pills from a category 3 to a category 2. This change now supports that pharmacists can offer POPs as an alternative option for patients with these liver conditions. In the case of sickle cell anemia, combined hormonal contraceptives have shifted from a category 2 to a category 4. So this would make them no longer permissible under the statewide protocol, but pharmacists can still offer progestin-only pills, which remain an appropriate option. With systemic lupus, that was once a blanket contraindication for both combined hormonal contraceptives and progestin-only pills, but that's changed. POPs are now a category 2, which means that they can be safely prescribed by pharmacists under the protocol in many lupus cases. And then lastly, chronic kidney disease is a newly added condition in the 2024 US MEC recommendations. The ability to prescribe progestin-only pills or POPs is an option. However, it depends on the patient's potassium status, and I'm going to go over that in a little bit more detail in an upcoming slide. Just recognize that this chart also is part of a new resource document that we've added to the Hormonal Contraceptive Toolkit on NCAP's website. It offers a clear, pharmacist-friendly summary of the changes that I've discussed here, but if you also haven't seen it yet, I highly encourage you to check it out because it does contain more detail in the document than what I'm showing here in this slide. So now let's take a look at what these changes look like in the patient questionnaire, and moreover, show the before and after versions, or the old version and the new version of the questionnaire, so that you can actually clearly see where and how these revisions change your treatment recommendations. Now, if you remember the patient questionnaire, beginning with part 3, under the medical history, you'll note that on the left-hand side here, which represents the old version of the questionnaire, any answer of yes to any questions 21 through 29, the resulting treatment pathway would yield a hard stop, requiring the pharmacist to refer the patient to the PCP for further workup and contraceptive care. In other words, all of these conditions that are asked about in questions 21 through 29 represent a category 3 for both combined hormonal contraceptives and progestin-only pills. You'll also note that question number 23 here and question number 29 that ask about liver disease, hepatitis, liver cancer, and jaundice was included in the original hard stop in the old questionnaire. In contrast, on the right, which represents the new version of the questionnaire, you'll now note that questions 21 through 28 are only representing a hard stop, requiring PCP referral, and that malignant liver cancer has now been carved out of question 29 down here and has been added as a standalone question, which now occupies question number 23 in the new version of the questionnaire. This was previously where lupus was, but lupus has been further moved down the questionnaire, and I'll show you where that is in just a minute. Also recognize that on question number 29 now, which only reflects liver disease from the perspective of cirrhosis and benign liver tumors, this is now again a lower restriction level for progestin-only pills, which offers this up as an option for pharmacists to provide for a patient who checks yes to this condition. Moving further down the questionnaire, as you can see from this slide, several new questions were added to the revised version of the questionnaire to reflect updates related to sickle cell anemia, lupus, and chronic kidney disease. These now appear as questions 43, 44, and 46 on the new version of the questionnaire on the right-hand side. Because of these additions, we also had to, of course, realign the numbering sequence of some of the questionnaire. So now you'll note that question number 43 in the old version on the left is now question number 42 in the new version on the right. Question 43 and 44 in the new version are brand new questions that were added specific to address the US MEC updates for sickle cell anemia and lupus. Question 44 in the old version is now question 45 in the new version. Question 46 in the new version is now a new question that addresses chronic kidney disease. Questions 45 and 46 in the old version have now been renumbered as question 47 and 48 in the new version. Now, regarding treatment options, in the new version, progestin-only pills are now considered clinically appropriate for any patient who answers yes to any questions 42 through 44, based off the revised US MEC criteria. For question 45, which addresses the history of gastric bypass surgery, the patch remains a valid alternative option and has gone unchanged from the previous version. For question number 46, which addresses chronic kidney disease, progestin-only pills can be offered depending on the patient's potassium status as it aligns with new US MEC criteria. And finally, part 4 of the questionnaire, which addresses the patient's use of concomitant medications, this section remains unchanged. Anyone answering yes to being on any of these medications still represents a referral and a hard stop for pharmacists, where they have to refer the patient to their primary care provider or their women's health care provider for further contraceptive care. Now let's talk a minute just to focus on question number 46. Again, this new question to the revised version of the questionnaire, which addresses the condition of chronic kidney disease. Now, as I mentioned earlier, the treatment decision for patients with chronic kidney disease is directly influenced by their potassium status. So if a patient answers yes to this question, then progestin-only pills can still be offered under the statewide protocol, but there's an important caveat here. Again, if hyperkalemia or high potassium is known or suspected, then drospirenone-containing progestin-only pills should be avoided. Instead, norethindrone is the safer choice, as droperidone in this case would be contraindicated in the presence of elevated potassium. Now, again, highlighted in the blue in the treatment care pathway, we've given you a few clinical pearls to help guide your decision-making process. So just bear in mind that if the patient's potassium level is unknown, then you can't go wrong by defaulting to using norethindrone. As a matter of fact, it's the safest. So if you don't know the patient's potassium status, you can still give norethindrone. Now, you could also do a couple other things. If you prefer to confirm the patient's potassium status, then you could consider contacting their primary care provider for documentation of any recent potassium lab. This would give you the flexibility to make the choice of which POP you might want to use based off of objective data. I would just highly recommend that you make sure that you're recording and documenting what those levels were and what choice you made and why you made it. Alternatively, you could also refer the patient to their PCP or women's health provider for a potassium check if you want something more current. Or ultimately, you can simply refer the patient to their provider if you feel uncomfortable with any of these decisions and just would prefer that the patient seek contraceptive options through their primary care provider or their women's health care provider. So it's totally up to you. But again, you can't go wrong in the presence or absence of hyperkalemia by going with norethindrone as an option. Of course, if the patient's amenable too. Now that wraps up our overview of the 2024 US MEC updates, how they've shaped the revisions to the North Carolina's Pharmacists statewide protocol for hormonal contraception. I hope you found the information clear and useful as you continue to provide this important service in your practice. Just add a quick reminder that everything we covered today, including this recording, any updated documents, and additional support materials, they can all be found in NCAP's Hormonal Contraceptive Toolkit. It's designed to be your go-to resource for everything related to pharmacist-prescribed contraception. And I encourage you to bookmark it, revisit it often, and let us know if there's anything missing that could better support your practice. We're always open to feedback to ensure that the toolkit continues to meet your needs. So again, I thank you for your time and for the work that you do to expand access to contraceptive care in North Carolina. And should you have any questions, please feel free to reach out to us. All right, thank you.